So first up today, first speaker, you recall Dr. Kelly from yesterday. In today's talk, he will talk about pain management in 2023, non-opioids, cannabis, terpenes, flavonoids, and opioids. Please welcome Dr. Kelly.
Good morning. I am standing in for Dr. Sandy Sambar. He was going to talk about terpenes, but he asked me to give this lecture on pharmacokinetics and pharmacodynamics of cannabis. And I apologize, I have a little bit of a sore throat, probably all the travel in the dry air. So I apologize if I have a scratchy voice. So we all know about cannabis. It's not working. Hi. This is right. This one, correct? Oh, thank you. Oh, thanks. There we go. Okay. So I think looking through at the crowd, most of us were alive in the 60s and 70s. So we know about cannabis, more commonly known as marijuana, Mary Jane, weed, the grass, pot, dope, reefer, tumbleweed, Maui Wowie, devil's lettuce, green goddess, Cincinnati, and it has a bunch of other names, but they were very popular. It's actually the most widely used illicit drug around the world. Approximately 192 million people use marijuana around the world, so it is the most commonly used drug. It's also highly controversial. We see it here in the United States. It's a Schedule I drug, which means it has no useful purpose, and yet it's legal in many states. It's also a drug that's difficult to classify because when you smoke it, it's very sedating. So it's a sedative like a barbiturate, and higher doses will actually alter perception, particularly perception of pain. But unlike a barbiturate, it doesn't produce anesthesia, and you don't get, it doesn't have toxicity, and people don't die when they have high doses. And it doesn't seem to have any cross tolerance with any other drugs, and therefore it must have unique binding sites that other drugs don't bind to. So it is in its own mysterious class of drug. So there are three types of cannabis plants. There's the cannabis sativa, which is probably the one that we know most commonly here in the United States. It grows fairly tall, it's very leafy, and it's the leaves that are smoked. There's cannabis indica. This is found mostly in India. It's a shorter plant, but has a higher THC content. And then there's cannabis ruderalis, which is grown in Northern Europe and Asia, and it has lower potency than the other two. The cannabis plant does not self-pollinate, so therefore there is a male plant and there's a female plant. And the female plant exudes this tarry substance so that the pollen from the male plant will bind to this tarry substance in order to pollinate it. So as far as its chemistry, we always think of marijuana as THC, but really there are almost 500 different compounds in 18 different classes in marijuana. THC is a phytocannabinoid. Phyto meaning plant, cannabinoid being the class of drug that it's in. And there are over 70 different phytocannabinoids, and we only know THC and CBD. So this is THC, delta-9 tetrahydrocannabinol. It has a concentration in plants somewhere between 10 and 30%. Of course, marijuana over the years has been cross-pollinated to increase the concentration of THC. So sometimes it goes as high as 30%. Cannabidiol is actually the thing that we like to think about for pain control and sedation. It has no psychotropic properties and is found in lesser amounts than THC. THC exists as an inactive monocarboxylic acid in cannabis, and therefore we have to heat it up. We have to smoke it, We have to somehow heat it up in order to decarboxylate it and go from the inactive substance to the active THC. It's stable in terms of it doesn't degrade easily. You can wrap it in aluminum foil, put it in your freezer, and it'll last for many, many months. The pharmacokinetics of cannabis. So what is pharmacokinetics? What is pharmacodynamics? Pharmacokinetics is what happens to the drug. How do you get the drug into the body? How do you get it out of the body? So if you start in the upper, I don't have a pointer here that will show, but if you start in the upper left, you take the dose of the drug and you ingest it in some way, and then it has some concentration in the body. It gets distributed around, acts in some way, and then gets metabolized and eliminated. That's pharmacokinetics. Pharmacodynamics is what does it do to the body? Is it toxic? What is its efficacy, and what is its pharmacologic effect? So we're going to talk about pharmacokinetics and then pharmacodynamics. So first, we have to get into the body, right? So that's what we call absorption. So we just talked about how we have to take the THC, we have to heat it up in order to form the active formulation. So this most commonly inhaled. So we burn it and then inhale it, either smoking a joint or using, as this young lady is demonstrating, using a bong. Now you have to heat it up to 120 degrees C, so it's very hot. So what bongs do, as this woman is demonstrating, she lights the leaves, inhales it, and then it goes through a water bath in order to cool it down before she brings it into her lungs. About 25% of the THC is absorbed and delivered into the systemic circulation when it's inhaled. It's very rapid. It goes from the lungs into the bloodstream quite rapidly, and the psychotropic effect happens within seconds to minutes. It has higher blood levels initially than orally. Orally takes much longer, so most people prefer to smoke it. And also its pharmacodynamic effect is shorter than oral administration. Absorption of THC depends upon how deep a breath they take, how much they inhale, how long they hold it in, and the puff duration. Another way to get into the body is by vaping. Vaping is shorthand for vaporization. So they take the THC, they heat it up, they infuse it into oil, and then the oil is vaporized and inhaled. Again, just like smoking, it is rapidly delivered into the circulation, and the psychopharmacologic effect happens within seconds to minutes. It has the advantage that it doesn't have all the tars of smoking it. You don't get the carbon monoxide or the aromatic hydrocarbons that you would if you were to smoke it directly. But we haven't studied it well. There have been people who have been admitted to the emergency department who have been vaporized using oils that had vitamin E in it, and it caused some toxicity in lungs. So this is an area that still is ripe for study. You can also eat it, but you have to heat it first, right, to activate the THC. So they bake it in cookies or in brownies. They heat it up in oils. They make butters out of it. You can have tea. So there's many ways to do it. But this form of absorption is much slower and much more unreliable than smoking it. It has lower bioavailability because it goes into the stomach and then it goes to the liver for a first pass effect. So the amount that is actually available to the body is much less. So the peak levels of the cannabis is much lower, and the systemic availability is only about 4 to 5% versus 25% for the smoked version. Onset is slower, whereas when you smoke it, it comes on in seconds. When you eat it, peak plasma concentration can be up to an hour or two. There are also synthetic THCs on the market. Marinol was very popular during the AIDS crisis because it stimulates the appetite and helps treat nausea and vomiting. Again, it's just like eating the cookies or brownies. They also will have a first pass effect in the liver, and also the delayed onset of an hour or two. And systemic availability is down to about 10 to 20%. So if you compare these, the absorption of 3 different ways that it can get into the body, back when this study was done, they actually took the THC and made it into intravenous form. It's not readily available that way, but they found, and that's the dashed line, the short dashed line. They found that the absorption intravenously was almost instantaneous, and then smoked was the second. You get slightly lower peak effect, but very, very rapid. And then the solid line is oral administration, that you eat it, you may not feel like anything's happening, but then over time it actually comes on. And actually that could be quite dangerous, because somebody may go to a party and say, well, I want to get high and I will eat a brownie. And they go, well, nothing's happening. They'll eat another brownie, and then nothing's happening. I'll eat another brownie. And then an hour later, they are very, very high. There is also a form that you can actually administer under your tongue. It's called Sativex, and it's 2 studies out there have shown that it's been very effective in the treatment of sleep apnea. They have fewer waking up episodes through the night when they use this sativa. But the absorption is highly variable, and the blood levels are much lower than either oral consumption or inhaling. There are creams out there and ointments that you put it on your skin, but this is a very, very ineffective way to get the THC absorbed into the body, because the THC is hydrophobic and the skin will not let it cross. So the aqueous layer of the skin prevents it from crossing. So they do have it out there, but it's not very effective. Okay, so we talked about absorption as far as pharmacokinetics. Now let's talk about distribution. So we've got it into the body. Where does it go? So we're distributing it into the tissues. Well, first of all, it goes into the bloodstream. If you inhale it, it goes into the lungs and gets absorbed into the bloodstream. If you eat it, it goes into the, gets absorbed, and goes through a first pass effect through the liver, and then is in the bloodstream. It gets distributed first into the blood, and then it goes to the brain, which is highly hydrophilic. And then it goes to high perfusion tissues like the heart, the liver, the kidneys, and then it goes to low perfusion tissues like like muscles, and then finally it gets absorbed in fat. Now the fat actually acts as a storage depot for the cannabis, the THC, and therefore people that smoke it chronically will actually have levels that are detectable for long periods of time. Protein binding is about 97%. Okay, so how is it eliminated? So we've got it in, we distribute it, and now it needs to be metabolized and eliminated. So it's metabolized in the liver using the cyclone P450 system. And also, depending on its route of administration, it gets metabolized differently. There are inactive metabolites as well as active metabolites. There have been over 100 metabolites that have been identified and then usually excreted in the liver, in the urine. Body fat does make a difference, since it's a storage depot for THC. That people who have higher body fats, it takes longer for them to eliminate it. So if you're going for a urine drug test for a job and they're chronic smokers, it may take several weeks for it to be undetectable. So on this graph, the body fat is on the x-axis and the time to clear in days is on the y-axis. And you can see as the body fat goes up, it takes longer for the THC to clear because it's stored in the fat. And you can see, compared to other drugs, the first line is single-use marijuana. It's in the blood, in the urine for 1 to 7 days, but clears the bloodstream in about 24 hours. If they're regular or chronic users, it can take up to 100 days to clear it in the urine, and about a week to clear it in the bloodstream, depending on the test. Compared to amphetamines, you can detect in the urine for up to 3 days, cocaine as well, heroin up to 4 days, and PCP up to 7 days. CBD has similar pharmacokinetics to THC. CBD is what we use for, or have been doing research on, for pain control. Its distribution and systemic bioavailability are very similar to THC. Okay, let's talk about pharmacodynamics. How much time do I have? Okay, good. Good. Okay, so now we talked about what happens, pharmacokinetics, absorption, distribution, and elimination. Now we'll talk about pharmacodynamics. What happens? What does this drug do to the body? Okay, so it goes in and binds to a receptor on the cell membrane. So you can think of it like a parking meter, right? The old parking meters, you could put a quarter in, but you couldn't put a dime in, you couldn't put a penny in. That's the same with receptors. Receptors are very unique. You have to it has to be the right receptor and the right ligand. So if the parking meter only takes a quarter, you can't put a dime in there. It won't work, right? So these receptors, there are receptors there for THC. Now, why do those receptors exist? It must mean that we have a system in our body that actually utilizes some endocannabinoid. And we'll talk about that in a little bit. So they act on that receptor outside the cell membrane. It causes some action that goes through into the cell and either antagonizes or agonizes some kind of action, some kind of pharmacologic effect. And so these receptors are part of the endocannabinoid system. And this is where phytocannabinoids act. Phyto meaning plant. So phytocannabinoids are plants, but we have an endocannabinoid system in our body. Now, you can think of it same as opioids, right? We have new receptors, which are endogenous opioids bind to. Well, we have an endocannabinoid system. So we produce in our body cannabinoids that bind to the system. And THC is similar to that. And so it will bind to those receptors as well. And this system is very ancient and evolutionarily conserved. So it must serve a very important role. It's millions of years old. If you trace it back through all the different species, it's found in all vertebrates. It's located throughout our entire body. It's active in utero and throughout our lives. So it must have an important regulatory function in our body. It's all involved in a number of different processes. I listed them here. It's involved in neural development, immune function, inflammatory processes, appetite. You know, the people who smoke get the munchies. It has something to do with appetite and metabolism, energy homeostasis. It affects the cardiovascular system. People who smoke get tachycardic. It affects digestion, bone development, bone density, neuroplasticity, pain control, which is why we study it so much. It's involved in the reproduction system. It has something to do with psychiatric diseases, particularly psychosis and schizophrenia. It seems to impair memory for people that smoke it. So it has something to do with memory, as well as sleep-wake cycles and also regulation of stress. So this is sort of a cartoon of what we know. We don't know a whole lot about it. We have two known receptors. They're called the CB1 and CB2 receptors. And so you see that in green and blue there. So those are the receptors that sit on the cell membrane that our endocannabinoids bind to. We know that we have endocannabinoids, and we've identified a couple of them. One is called anandamine, or AEA, and the other is 2-AG. And you can see those at the top there. So these are the endocannabinoids that we in our body produce, and they bind to CB1 and CB2. And then we have, and then there's a system to actually metabolize those, and those are the fatty acid amide hydrolase and the monoacetylglycerol lipase. So those are responsible for metabolizing the ligands once they act on the cell membrane. So where do these CB1 and CB2 receptors reside? Well, they reside in different places, and they actually seem to have slightly different processes. So the CB1 receptor has almost 100% amino acid homology with other species. So so evolutionarily, it's very, very well preserved. They find it in mice, they find it in rats, and they find it in almost in all vertebrates. It's mostly located in the neurons of the brain, spinal cord, and the peripheral nervous system. And it's also in the endocrine glands, it's in leukocytes, spleen, heart, parts of the reproductive, urinary, and GI tracts. The CB2 receptor is about 50% homologous across all species, and it's concentrated in the immune cells. So this is what it kind of looks like. This cartoon's a little complex. I'm not going to go through all of it. But for those of you who are doctors, you are taught in medical school Well, there's a presynaptic membrane and then the postsynaptic membrane. The action potential heads down the presynaptic, releases vesicles into the synaptic cleft. It goes across the synaptic cleft, binds to the postsynaptic membrane, and causes whatever action is going. Well, this endocannabinoid system works in the opposite direction, which in my mind, is absolutely amazing. So actually, the endocannabinoids in our body are actually produced in the postsynaptic membrane, and then they're released, go across the synaptic cleft, and actually bind to receptors in the presynaptic membrane and terminal. So and this is what we see. So number one on this cartoon is the formation of the endocannabinoid. It goes out into the synaptic cleft, and then goes over to number two, where it binds to the CB1 receptor. And that's where our own endocannabinoids act, as well as THC acts on that same receptor. And then it does a bunch of things inside the cell. It opens and closes calcium and potassium channels, does a bunch of other things, and then causes its action. So just looking at this, you kind of see that if we have things like epinephrine and norepinephrine that are being that go from the presynaptic membrane to the postsynaptic membrane, then somehow the endocannabinoids have some kind of modulating effect on the presynaptic membrane to maybe slow things down a bit. Okay, so our endocannabinoids are this AEA and 2AG. Those are the two that we know about. There's probably many more. Those are the two best studied. The ones that mimic our endocannabinoids are the ones that we know about. There are many more. The phytocannabinoids, which is THC and CBD. So these are coming from the outside, mimicking actually endocannabinoids that we have in our own body. So the THC actually has affinity for both the CB1 and CB2 receptors, but seems to be more efficacious at the CB1 than CB2. And we don't know exactly how CBD works. But there have been 66 cannabinoids, phytocannabinoids that have been identified, and of course, we've only studied 2 of them. So then once they bind, whether it be an endocannabinoid or THC, then these FAAH and MAGL will then hydrolyze and metabolize these and terminate the action. So now we're talking about, okay, so what happens? So it binds to this membrane, and then it causes all these effects, either antagonizing effects or antagonizing or agonizing effects. They've done studies. The toxicity for THC is actually it's very low toxicity. They took monkeys, this is back in the 60s, they took monkeys and they dosed them up to 900 milligrams per kilogram. And normally we probably absorb maybe 1 milligram per kilogram when we smoke THC. So these are massive doses, and none of the monkeys died. Other than what I'll tell you a little later, there haven't been any fatal cases of THC toxicity known. So it seems to be fairly well tolerated. Neurologically, there are some good things that happen. It seems to be very good at helping people who have different kinds of neurologic spasticity disorders because of its modulating effect on the cells. So that's a good thing. It improves sleep quality. It makes people sleepy, and people sleep well. Those that have sleep apnea, it seems to help them with their sleep as well. There have been studies out there that have indicated that might be helpful in migraine therapy as well. So these are all very good things. It does impair motor function and coordination. So if somebody's operating machinery or they are driving a motor vehicle, this probably is not such a good thing. Also causes drowsiness. Again, if you're in a situation where you need to be alert, this may or may not be a good thing. If you try to get sleep, it may be useful. So that may not be such a positive thing about THC. What about pain management? Well, CBD seems to be very effective in treating chronic pain. It also seems to manage inflammatory processes such as rheumatoid arthritis. So these are all both very good attributes of THC. How about cancer management? Well, it's very good at helping with the pain and discomfort of chemotherapy. It's very useful in managing nausea and vomiting as a result of the chemotherapy or other illnesses. And it also stimulates the appetite. So it's good for anorexia and also in the anorexia that is secondary to chemotherapy. So those are all very good things. What about cardiovascularly? Well, it elevates the heart rate. We're not too sure why, but there's some feedback mechanism that causes tachycardia. There's been no reports of anybody dying from the increased heart rate, but anybody that has advanced cardiovascular disease may be at risk for a myocardial infarction. So I'll put a little question mark by that as to whether that's a good thing about THC or not. Gastrointestinally, it seems to be useful in treating inflammatory bowel diseases, but it does cause a dry mouth. I don't know if that's very useful for anybody. It can cause vomiting, and that's not a good thing. And then there's this new syndrome called cannabinoid hyperemesis syndrome, which has been noticed in young people who smoke marijuana chronically. It causes increased vomiting, dehydration, and abdominal pain. And it seems like the only treatment for it is to take hot showers. In fact, people it's so debilitating that people take hot showers to the point that they actually scald their skin. And there have now been 4 reports of young people who have died from this cannabinoid hyperemesis syndrome. So it's not completely benign. So that's not such a good thing. Reproductively, it seems to decrease fertility. There was a study that came out of my institution, UCI, University of California, Irvine, about 2 months ago, where they took rats while they were adolescents. They administered THC for a period, every day for a period of 2 weeks. They let them grow to maturity, and then they took a look at the number of eggs that they had, and they saw that the number of eggs that these rats had decreased by 50%. So they think that perhaps this may be a problem, that if adolescent girls are smoking THC, that they actually may be destroying the eggs, and the fertility rate may be going down. 2 minutes. Okay, great. Thank you. There was a study that came out in 2018 that also showed that men who smoked marijuana chronically had decreased sperm count. So decreased fertility looks like not such a good thing. Also, it seems to affect pregnancy. We're not too sure about this. People that smoke, women that smoke marijuana chronically seem to have low birth weight babies, but we don't know whether it's a result of the smoke or a result of the THC. Psychiatrically, certainly, it seems like cannabis seems to play a role in depression. In this graph, this was out of Belgium. They had 56,000 participants who had cannabis use disorder, and those that had a cannabis use disorder were at much higher risk for unipolar depression than those that didn't. So cannabis may play a role in depression. How about suicide? Well, it looks like this is a report of suicides from the poison control centers. And it looks like each one of these graphs, by color is the year, and then it's by age group. So on the x-axis is age group, and then it's by year in color. And you can see that every year we've been seeing increasing number of suicides that are related to cannabis use. I don't know whether this is a cause and effect or whether it's just coincidental. There are a lot more studies that need to be done about this, but it certainly is something to be concerned about. So overall, yeah, there are good things. Treats spasticity, improves sleep, migraines, treats chronic pain, inflammation, good for side effects of chemotherapy, treats nausea and vomiting, helps with anorexia, it treats inflammatory bowel disease. Some things that may be good, maybe bad, it makes people a little bit more impaired in terms of the coordination, causes drowsiness, increases heart rate, and causes a dry mouth. But certainly the stuff that we think is ugly, this cannabinoid Hyperemesis syndrome is very worrisome. Decreasing fertility among young women, decreasing sperm counts, the effects on pregnancy, and also this new data on depression and suicide are all things that I think that we should be very, very concerned about. Thank you.